See a lot of great attendees tonight. Thanks again, everyone, for spending your evening here with us this evening. We're really excited to talk about this topic. This is our first session of our education sessions at Whole Health. We have a schedule of different types of webinars throughout the rest of 2025. So please continue to stay engaged with us. But we're really excited to talk about Insulin Icodec today, which many of you may have heard about, but may not be super familiar with because it's Canada's first once-weekly basal insulin coming out just the previous year, but still not used as much. And we'll get into a little bit why. A lot of it is coverage related, but lots of comments on that later. As a disclosure, we thank Novo Nordisk for the support for this program, but we, of course, want to highlight that all of this content was developed by Whole Health and not necessarily reflects the views of Novo Nordisk, but we do, of course, always thank our sponsors, Novo Nordisk in this case, for sponsoring pharmacy education. So many of you already know me. I run pharmacy programs and education at Whole Health. For those who don't know who Whole Health is, we're a national independent pharmacy banner with over 250 locations across Canada. As I discussed, this is the first webinar that we have this year, so we're super excited about it, but we have webinars throughout the year, so make sure that you stay connected with us. And if you would also like to learn more about our independent banner program, please also reach out and we would be happy to meet with you. This evening, I'm pleased to be joined by two great guests. We have Judy Trong, one of our amazing pharmacy students from the University of Toronto. It's her last week with us here this week, so really happy she was able to stay to present some of these slides on Icodec. And last but not least, I'm very pleased to be joined this evening by our special guest, Siva Sivapalan, who many of you guys know as an educator and a thought leader in pharmacy. He is a pharmacy manager within our banner and a true expert in this area. Siva will be jumping in throughout this presentation and answering some of your questions and bringing his wealth of diabetes clinical experience to this session. So happy to have you, Siva. I'll go through the agenda now. So we'll do a broad review on barriers to glycemic control, followed by an introduction to the characteristics of insulin Icodec. We'll then go into the trials that went into insulin Icodec before it got approved. We'll go over the formulation, dosing, storage, everything your pharmacy teams need to know to be able to support patients with this product. We'll review coverage, we'll review the pharmacy role, relevant patients that you may want to start the conversation with, and we'll go through takeaways as well. So we won't go through all of these opportunities right now, but just for you to consider as we go through this presentation, we'll get back to it at the end of the presentation, but which one of these patients would you consider recommending or at least starting the conversation for insulin Icodec? Case A is a female age 29 who has type 2 diabetes on oral diabetes medications and starting basal insulin regimen and is functionally independent. B is a female age 75 who has type 2 diabetes, recurrent hypoglycemia, and on basal bolus insulin regimen. Case C is a male age 52 who has type 2 diabetes on oral diabetes medications and basal bolus insulin regimen, but not hitting his glycemic targets because he's not adherent to his medications. And he has no history of hypoglycemic events. And we have a female age 25 with type 2 on oral diabetes medications and basal insulin regimen with an A1C at target goal. So think about some of these cases, and it doesn't have to be these specifically, which we'll go into later, but also think about your own practice and patients who may be similar to some of these cases or may have differences. And think about how, as we go through this presentation, insulin Icodec may or may not play a role. So before I pass it off to Judy to talk about insulin Icodec, I just wanted to do a general review of glycemic control. And as we know, as pharmacists in our day-to-day practice, there's many patients with diabetes when they're either moving from oral therapy to insulin, it's a huge step, right? And that injection burden can be a significant barrier. And both the patients, as we mentioned, starting insulin, but also those who have been on insulin for a long time and become overwhelmed with multiple daily injections. So going over some of these stats, half of people with type 2 needing insulin therapy delay initiation by an average of 15 months, and this can significantly impact their glycemic control. 1 out of 3 of all individuals with diabetes are not adherent to daily insulin therapy. The majority of physicians note that the frequency of daily injections poses a challenge for patients. And so, all 3 of these illustrate the impact that adherence to medications and that injection burden can impact adherence, which overall impacts diabetes control and that progression of diabetes over time. And so it's exciting when we have new advancements in technology in this space. And we've done other webinars on different topics with, needle-free injectors as an example. And we're excited to talk about Insulin Icodec today, because with once weekly dosing, we can hopefully improve patient adherence compared to once daily dosing, and that improvement in patient adherence will really impact their overall glycemic and diabetes management.
Molly, it's okay if I just add some thoughts to that. Thank you so much, and thanks for inviting me in just to share some thoughts. I really empathize with everything you've just said, and just to provoke some thought with these points. 59% of physicians noting that the frequency of daily injections poses a challenge for patients. So there's some real clinical inertia here. So if a healthcare professional feels that, there could be like an unconscious inferring to a patient that insulin therapy might be problematic when it isn't, right? There's all these sort of unconscious biases that the patient will pick up on, and that might lead them to delay even considering insulin. A third of patients not being adherent to therapy. I just wanted to introduce one concept here where we have a patient in community pharmacy taking a basal insulin, and in that titration phase, they might be taking 10, 12, 14 units a day. Because they might not be adherent, they might miss 2 or 3 doses weekly. I just wanted to introduce the concept of them titrating up their insulin despite the fact that they're not adherent, which can inadvertently lead to hypoglycemia because they're over-basalizing. So I just wanted to introduce that concept of over-basalization, where you might be taking too much basal insulin for a number of different reasons. So just some sort of clinical considerations there I wanted to introduce.
Yeah, that's such a great point, Siva. And, we simplify it to non-adherence, but there can be very significant downstream effects and complications to their management overall, right? Great to bring up. Excellent. Okay, passing it off to you, Judy.
Okay, great. Thanks so much, Molly. So now I'm going to be going over Insulin Icodec, the actual product. So unlike conventional insulin, which needs to be injected multiple times a day, Insulin Icodec, it works as a weekly injection. So it's injected once weekly subcutaneously. And then because it's only given once every week, it's very convenient for patients. So you can see here, instead of doing 365 injections in a year, patients would only need to do 52 injections if they're injecting once every single week. And then the advantage is that if you're giving fewer injections, it really reduces the treatment burden and the complexity of the insulin regimens. It makes it a lot more easier for patients. As well, it's very convenient for them, so it's easy for them to continue this regimen and accept it and adapt it. And if they're adherent to their medications, essentially it'll help them to improve their glycemic control. So,
Judy, do you mind if I add something to that? If that's right.
sure.
Thank you so much. Really, really good clinical points on how adherence can improve glycemic control. I just wanted to add one thing in. As community pharmacists, often we deal with caregivers. And one thing I see in practice, whether it's in primary care or community pharmacy, it's often the adult son or adult grandchild that's in charge of giving once weekly GLP-1 therapy, for example. So when we're considering basal insulin for patients, this actually might make it more likely that they'll be on basal insulin, because they might think that daily basal insulin isn't going to be feasible because the adult child or adult grandchild isn't able to administer medication for them. So there's a lot of vulnerable adults out there that are our patients that depend on their caregivers to administer medication. I just wanted to throw that out there, as this this therapy really creates an opportunity to introduce insulin where it otherwise may not be considered. Just wanted to introduce that.
Yeah, that's great, Siva, on the accessibility point.
So here's a slide essentially on how Insulin Icodec works. So first, the Insulin Icodec, it's injected subcutaneously. So although 1 week's worth of insulin is administered, almost all of the icodec actually binds to the protein in the blood, albumin, and this binding to the albumin is what forms the inactive depot. So from this inactive depot, the insulin icodec gets slowly released from the albumin to achieve that glycemic control throughout the week. I can see here in this graph, just to illustrate the kinetics of the drug, but essentially after giving about 3 or 4 weekly doses, the insulin icodec will achieve a similar glucose lowering effect at steady state, but with considerably fewer injections compared to the once daily insulin. Since it does take some time to reach that steady state in some patients, sometimes they'll need a one-time additional dose, which we'll be going over later in the presentation.
Thanks, Judy. Is it okay if I weigh in this as well? Thank you so much. So, guys, insulin Icodec has a half-life longer than any other insulin we've ever seen before. So because of that, like Judy said, there's so many clinical considerations about how long it will take to perhaps see the effect of the drug. So especially when we're in some of our patients where we may convert someone from degludec or Tresiba to Icodec, if we don't do a loading dose, for example, to get to that steady state quicker, there's a number of things that could happen downstream. So some people are totally fine with that. If we warn them, look, you might be high for 2 to 3 weeks, that transient hypoglycemia, but it could result in the patient thinking, okay, this neuroinsulin isn't working at all. I'm running high because 2 to 3 weeks is a really long time if you think about it to be running high, especially for patients used to being more closer to target. So as pharmacists, I think, and even primary care physicians, giving a loading dose, especially of insulin, we might be afraid of doing so. But the onwards trials that Molly's going to talk to later, it really showed the safety of giving that loading dose, which we'll go into in depth later. So I just wanted to put it out there early on that the loading dose has been shown to be safe, and the trials showed that. And even though it's our clinical discretion to do it, just be mindful that it is safe.
Yeah, that's a great point, Siva. And when we were first learning about insulin Icodec here at Whole Health and trying to place it within therapy and thinking about its use in pharmacies, that loading dose point was confusing, right? And I think for a lot of pharmacy operators out there and for a lot of frontline pharmacists, when you're in these situations, when you're deciding or you see prescriptions with or without the loading dose, I think we'll get into a little bit later, but what you said exactly, in that it is safe. It does help because of the pharmacokinetics of the product to get that patient to where they should be in terms of that steady state of insulin. So we'll review a little bit more later, but very important point.
Thanks. Molly, can I share a reflection? Just to add on from that. When I graduated from pharmacy school, just because of my training, like there was so much fear associated with starting insulin, and it was viewed to me as like a dangerous drug, where in fact it's actually a very safe medication, and all these sort of particulars, especially for pharmacists that qualified a long time ago like me, just changing that shift, because now we're often, because of all these newer medications that have come out, like GLP-1 analogs, like SGLT2 inhibitors, we don't really have to use whopping great big doses of insulin like we did before. So just adding on to that safety piece, I just wanted to add that. Thank you so much.
Okay. Back to you, Judy.
Great insights. So now I'm just going to summarize some of the trials behind insulin Icodec. So Icodec in the clinical trials of onwards 1 to 5, These studies were done in patients with type 2 diabetes. And in these studies, they compared patients who were the treatment arms for patients who were on insulin icodec versus daily basal insulin, so either degludec or glargine. And in these patients, they were either insulin naive or they had previously been treated with insulin. So the main findings of these trials was that in terms of A1C lowering, they found that insulin icodec was non-inferior or superior to the daily basal insulins in terms of A1C lowering, and more patients were able to reach their target A1Cs of less than 7% when they were using the icodec. In terms of, there was similar clinical benefit in terms of the time they were in the glycemic range, as well as their change in body weight when they were on the icodec. As well, when they were looking at safety in these trials, insulin icodec actually had similar low rates of hypoglycemia compared to the control arm. So it's generally a very safe product, and it has better A1C lowering properties. And then there was also another trial, so Onward 6 looked at insulin icodec in type 1 diabetes patients. And here the treatment arms were insulin icodec, which was compared to insulin degludec. So in terms of the main findings, the study showed that once weekly icodec was non-inferior to once daily degludec in lowering the HbA1c. There was also higher rates of hypoglycemia in the icodec group, which was statistically significant. So the implications of this trial showed that icodec could potentially be used as an attractive alternative for basal bolus treated individuals. So in practice, Health Canada has approved icodec to be used in type 1 diabetic patients. And the monograph does state that if patients are using insulin icodec, that it must always be used along with short or rapid-acting insulins. So although Health Canada has approved the indication in patients with type 1 as well as type 2 diabetes, it's not routinely used as much in the type 1 diabetic patients.
Judy, do you mind if I weigh in on this? If that's okay?
Sure.
Thank you so much. So just something to consider is that if any of the pharmacists on the call here look at the Onwards trials in depth, I would sort of point to the kind of targets that they were aiming for. Some of those targets seemed much more tighter than what I might do in my own clinical practice, which made me think maybe that's why in this trial the hypoglycemia risk was the way it was. Another consideration is that type 1 diabetes patient, they're going to be basal bolus, right? They need mealtime insulin to to deal with that carbohydrates with meals. So basal bolus insulin regimens ordinarily have a higher rate of hypoglycemia as well. So there's a couple of considerations there as well. The other Onwards trials, I believe, most of them, I think, focused on patients with icodec versus just basal insulin. So some things to consider there. And I'm sure this will evolve the use in type 1 diabetes. But Judy, you're absolutely right. It can be used in type 1 diabetes, and I'm sure we'll see that use evolve.
Siva, can I ask you a question? You talk to a lot of endocrinologists, both in your practice and also as an educator across Canada. When in those conversations, when you're talking to diabetes experts and endos, what are their thoughts or what is their perspective for the type 1 versus type 2 for insulin icodec?
For sure, yeah. So, I work with 4 family physicians in primary care. And like you said, I do talk to a lot of endos as well. I can say that in primary care, even using it in type 2, it's a new thing and it's going to take time to build confidence. One thing I want to share with the pharmacists on the call here is that you don't realize how much more that you know about medicines, particularly insulin, than a lot of physicians out there. And I'm not trying to blow on the trumpet of pharmacists here in any sort of way, but one thing I realized for my pharmacy practice in primary care, when I'm doing insulin titrations, dose adjustments, is that appreciation from physicians. Oh, is that how you do it? They don't know as much. They may not know as much as we do on these kinds of medications and how to safely titrate the doses. So to answer your question, Molly, I think physicians on the primary care side that I work with, I think Icodec will be something that's used more routinely than it was before, depending on coverage and all those other sort of multifactorial elements. In terms of endocrinologists, I think they will use it for type 2 diabetes routinely as the people as those physicians become more comfortable with the drug. But with type 1, something I've learned in practice as well, like a lot of type 1 patients, they're so sensitive to insulin, right? So the comfort just has to develop. Like we develop so much clinical discretion from my experience, right? So I think that will evolve. But I do see a place for this in type 1 diabetes, particularly with the endocrinologists. Family medicine, I'm not sure, but definitely with endos, if that answers your question.
That's great. Appreciate your insight, Siva. Yeah, and it just goes to show, I mean, it's so early in this product in terms of, as you mentioned, the coverage is still updating, so we don't see this widespread uptake yet. But as you discussed, we're really the medication experts, right? And so physicians, endos, they're relying on, you know, us oftentimes to, and the patients as well, to help them manage specifically relating to insulin. And so it's so important for us to talk about these new updates and especially be prepared when we get these questions as uptake continues to evolve.
Absolutely.
So I'm going to take over and go over some of the characteristics of Insulin Icodec. It is formulated as 700 units per ml. So that would be like saying U700 instead of U100, right? So it is much more concentrated so that a similar injection volume can be given compared to once daily insulins. It comes in terms of format, comes as a 3 milliliter insulin pen and a 1.5 milliliter insulin pen. For storage, if it's unopened, it can be refrigerated until the expiration date or at room temperature for 12 weeks. But as soon as you open it, then it's good for 12 weeks, regardless of whether or not it's at room temperature or refrigerated. Prior to using it, similar with other insulins, just make sure that the product looks all right, ensure the product is clear and colorless. It's also important to advise patients not to mix Icodec with any other insulins, not to use it more than once a week, but we'll get into the specifics in the next slide on that, and not to use it with any other long-acting basal insulins.
Molly, do you mind if I weigh in on that? That's okay. Thank you so much. I just wanted to share one thing from this slide. This is based on like the years of practice that I have in this space. Community pharmacy has such a unique opportunity to ensure adherence and then therefore therapeutic effectiveness of insulins, particularly basal insulins. And I can't stress how, in my practice, how beneficial it is to do a first dose with a patient. So I would recommend whenever someone's being started on any sort of basal insulin, whether it's Basaglar, whether it's Tresiba, whether it's Icodec, particularly with Icodec, I really encourage the pharmacist to, you know, I don't know how you let patients know when your prescription's ready. Maybe you text them, maybe you call them. I would pick up the phone and call and just say, look, I've got your insulin ready. I really think we should do a first dose together. Because Molly spoke to about the adherence rates to insulin just more broadly. It's multifactorial. They might be like, oh, it's an injection. But when you go through it and you say, you know, it's a 4 millimeter needle, they're like, that's not even an injection. That's like a 4 millimeter. You know what I mean? Just those basic things like that. And all these storage things that you can go through on the first meeting, they're probably going to remember only a third of what you say, maybe more. But it really, really does improve likelihood of success on therapy. So I just wanted to add that in there, just doing a first dose together. Another thing is, even the physician colleagues I work with, I've prescribed it 2 or 3 times in primary care. I work under a medical director where I can prescribe it. Prescribing 70 units as a starting dose, it is sort of like a sticker shock type of reaction, right? But when you explain that it's only 10 units a day and it's like starting to, you know, something like Tresiba 10 units a day, and they're like, oh, yeah, it is like that. so many benefits from doing the first dose together that I just wanted to explain. Sorry if I babbled there, Molly.
Oh, great points, Siva. Very important from a practice perspective. Yeah, I mean, if patients aren't able to remember, to be adherent, they preclude any benefit they would get from therapy, right? So important. On this next slide, there are some important points to remember in terms of dosing. As we discussed, it is injected once every week. Now, when you're starting patients, they can inject on any day of the week, choose a day. Obviously, it's more preferable to inject it on the same day every week. However, if patients miss a dose or they happen to inject it on a different day, that is okay, as long as at minimum, they space the injections by at least 4 days apart. In terms of timing, it can be injected at any time of day. It doesn't have to be at night, doesn't have to be in the morning. It can be any time that's convenient. So again, talking about the accessibility point of having it once a week and any time of the day, it's a lot easier for caregivers, especially for individuals who are not functionally independent. When we're taking a look at the effect of insulin icodec, the effect is highest on days 2 to 4. So when after you inject it, we see this peak on days 2 to 4. So it's important to advise patients and let them know that there may be an increased risk of hypoglycemia on those days. Patients need to know how to, similar with all insulins, how to recognize hypoglycemia, how to manage it, and make sure that they always have sugar on hand to manage that. And usually, I don't know what you like to do in your practice, Siva, what you recommend, but generally, it's probably best, especially when starting this, maybe, for 2 weeks going on a CGM, right? Just in the beginning phase, or maybe for a month going on CGM, just so we can visualize those patterns and, really make sure that you're off to a good start with it.
Yeah, with that CGM thing, I just wanted to weigh in. I can't stress how easy insulin dose titrations have become because of CGMs. So Libres or the G6s or G7s, particularly, like, I know most of the pharmacists are aware of that, but if it's connected with your cell phone, you don't even need to keep scanning it. It just keeps pushing data to your cell phone and it's there. It's made insulin dose titrations so much more easier. The ability to pick up on hypoglycemia, the ability to see that, if you have like a bowl of noodles, it's like toxic. It just goes like up like that. So I would just encourage everyone, where possible, try and convey the benefits. There's a lot of patients are like, oh, that looks ugly, I don't want to put that on there. But the benefit, at least, like Molly said, for, if you can convey that, let's at least try and do it while we're doing the dose titration phase. It would really help guide therapy and help pharmacists become more involved in it. I would also ask if there's any pharmacists on the call that have questions about this particular slide about missed doses, please put it in the chat, because this is a really, really new concept. So definitely ask questions about it. But Molly explained it really well, so thank you.
Thanks, Siva. And the last point on here is it's similar to other insulins. It's injected subcutaneously. So everyone's aware of the locations in the thigh, upper arm, or abdomen that you can inject. Also, another benefit would be less lipohypertrophy, right, from less injections.
Oh, yeah. Molly, you know what? The lipohypertrophy thing, I know everyone knows about it, but often in primary care, I actually palpate to see it's a thing for sure. And patients might be telling you that they're changing their needles, but often they don't. So it doesn't hurt to just remind them about the importance of changing needles and changing the injection site, especially if it's weekly. Like Molly said, it's much less likely, it's just a different quadrant each week, right? Super easy. So yeah.
Okay, in terms of dosing, which Siva already alluded to earlier, but there's 2 different buckets here. You have patients who are basal insulin naive, where there is a recommended starting dose of 70 units once weekly. And again, just to reiterate again, Icodec can be used with other oral diabetes agents and short-acting insulins as well. So if patients have never been on insulin before, the starting dose is 70 units once weekly. It does sound like a lot, but as Siva said, it's like taking 70 divided by 7 because it's a week. And so you get 10 units per day, which is standard. If patients are switching from another basal insulin therapy, a couple of considerations that we've set on the slide. Number one, as we've talked about it before, it's so important to keep a close eye on the patient's glucose levels, so making sure that they're monitoring. Again, if we can leverage CGM, especially in that initial phase, it would be very helpful. Another thing is doses and timing of concurrent short-acting insulin products. So other insulins or their other diabetes medications may need to be adjusted during this time. As with any transition to any insulins, anytime you're making changes in therapy or changing product, people respond differently, right, to different insulin products. So that's why, as the patient is getting used to this new product, there might need to be changes here and there with some of their other diabetes medications, which is why close monitoring is so important. In terms of when to start Icodec, it can be started the day after their last basal insulin dose. So let's say they did Tresiba yesterday. They can start Icodec today, anytime during the day. In terms of the weekly dose, instead of doing 70 units once weekly, if they were already on a basal insulin therapy, then the dose would be their previous daily basal insulin dose, right? So what they injected of Tresiba or whatever it is in units, and then times 7. So the number of days in a week times 7, and then rounded to the nearest 10 units. And then that would be the first week. And then subsequent doses can be titrated based on the patient response, the goals, whether or not it's being met. And there will probably be that period as we get to steady state, as we talked about, where there will be changes.
Well, I'm just monitoring the chat here. Do you mind if I answer a couple of questions?
Of course, yeah.
Thank you so much. Do you mind going back one slide? Because Farhan's got a really good question here. Hey guys, thank you for the presentation. Is there any info on how it is on the 8th day if they're a little late? That is a bloody good question. I had the same question when I was learning about this. So say that you take it on a Monday and you take it every Monday, you forget, and then you remember on a Wednesday. You can take it on the Wednesday and then resume taking it on the Monday, because you've given at least 4 days between injections, and because of the such long half-life, as Judy showed on that slide, it's safe to just keep resuming on a Monday. So Farhan, I hope that I explained that well. If I haven't, just ask the question again. Posh has got a question here. What if a patient takes injections 2 days in a row on day 1 and day 3? That is also a great question. The way I would answer that is I would really stress to use a Libre or some sort of CGM to monitor for hypoglycemia really closely. I believe, and I'd have to double check, that one of the onwards trials, you see how we came out with 50%, a 50% loading dose is really quite safe. I think they tested a double the dose loading dose, and they found also some pretty good safety data on it. But if someone's established on a particular dose and they take double the dose, you really, really need to keep monitoring for hypoglycemia and treat it accordingly. And there's different levels of hypoglycemia that some warrant referral to someone who can manage that in a hospital setting. But yeah, just make sure all the basics, that they're well versed on how to treat hypoglycemia. Where at all possible, use CGM. Make sure that they alert anyone who lives in their household about hypoglycemia and how to use Baqsimi. All those kinds of basic stuff. That's what I'd recommend. I hope I answered the question there. I don't know if Judy and Molly has anything to add.
Yeah, great point, Siva. I think just because of the way that the product is formulated, and because we're not going to see the effect right away, right? Because it is released through that depot, and as we talked about before, that peak is at days 2 to 4. So let's say day 1 and day 2, the patient injected it on day 1 and they don't see a response, so somehow they decide to inject it again on day 2. You would be concerned because now you have those 2 peaks coinciding at the same time, which is why likely within the monograph, you must space it by at least 4 days, because then you're at least giving time for the peak to really show before you give that other dose. And so there's another question there. If it's less than 4 days, if the injection day going forward would be on the day which they did their last dose. So in the example where Siva mentioned, if your injection day is supposed to be Monday and you forget and you inject on Wednesday, then yes, between Wednesday to Monday, there's enough time, more than 4 days. So then your next injection would be Monday. But let's say you forget until Friday, then your next injection would probably have to be pushed because there's not enough days between Friday and Monday to give that injection on Monday, if that makes sense. Right.
One
Yeah.
more question, right? If hypoglycemia does occur, will it be persistent? That is reoccur after treatment, given the molecules? Yes, that's a definite clinical consideration. Great question. So that's why I stress the importance of CGM. If it really comes down to clinical discretion, but it may need to be managed in a hospital setting depending on what you see, right? But you're absolutely right. It could persist, and it might require medical intervention to manage that. So that would have to be on a case by case basis. So I hope that answers the question.
And I think like looking at just like the slide that I'm just going to go back a couple of slides here so then we can see this graph again. This one, looking at the pharmacokinetics of it, where we would be most concerned, I guess, is in this initial phase when we're trying to titrate up to the right dose, right? And it's likely in this initial phase, if dosed correctly, and a lot of the times if you're starting on an insulin naive patient, that 10 units per day or 70 units per week will be okay. And if they're transitioning using their transition dose, as we talked about before, it should be okay. It does take time, right, for the molecule to build up within the body to get to steady state. So there is that. We do also reflect. I just want to say this because I don't want people to be afraid of insulin icodec in terms of the hypoglycemia risk, because when we do look at the summary of the trials, we do see a comparable rate of hypoglycemia. So as long as it's managed correctly and we don't have medication errors or administration errors or dosing errors, then it is safe. Another question from Janella: what needles are compatible with the pen?
They're universal. It's just the same. Insulin pen needles are universal, right? Like depending on which millimeters you need. So I hope that answers the question, Chanel. You could use the Novafine, the BD Ultra. Insulin pen needles are universal with the GLP-1 analogs that I know of. I haven't actually seen a Mounjaro pen because they've just come out, so I'm not sure about that. But with the Ozempic and all the other insulins, Trulicity is an auto-injector device, so it doesn't apply, but they're generally universal. If you're late, sorry if I'm taking time, well, I can answer these after.
No, these are good. Yeah, go ahead.
Really good questions. So if they're late, Friday instead of Monday, would you recommend that they continue dosing on the Friday? I would recommend at least just 4 days, like the monograph says, to resume, unless you guys think otherwise.
Yeah, I think, are they asking like if they're late and they notice on Friday, should they skip the dose and wait for Monday or just dose on Friday? If the patient is able to change their schedule around, I would say give the dose on Friday, obviously, because they've been without the insulin, right? But then they would need to adjust like the timing of their schedule.
Great question about experience in long-term care. Judy's going to talk to it about the cost per unit. It's pretty comparable. So Samira, I think there should be a place for this in long-term care in the future because especially if we're dealing with the kinds of doses we routinely use with basal insulin, like I don't often have to go above 30 to 40 units of basal insulin a day on a daily basis. So if we're talking about that, I think it's going to serve a considerable amount of nursing time in long-term care. So I think there is a place for it, but we'll have to see if there's coverage to support that.
Okay, we're going to move on to these next couple of slides, and then as we get more questions, we may answer them throughout the presentation as well. I didn't want to separate these two slides because we talked about dosing in if you have a patient on already established on basal insulin, and in general, the dosing is very easy. It's just their daily basal insulin times 7, right? However, in some situations, depending on the patient's glycemic control, their history of hypoglycemia, and how much you'd like to get them up to steady state earlier, there can be a one-time additional dose that is given on the very first time that they receive insulin icodec. So in these patients where there's where they're not at high risk of hypoglycemia, you want them, they're far away from target, and you want them up closer to steady state sooner, then the first week starting insulin icodec, what you do is you do the same calculation as before, where you take their previous daily basal insulin times 7, so that's their standard dose. And then for these patients, there's a 1.5 modifier. So this would be that additional amount that they would receive for this very first dose. So for example, if you had a patient who is doing 20 units of insulin per day, their standard calculation for insulin icodec dose would be 20 times 7, so 140. If they were a patient that required a one-time additional dose, so on the very first time that they start insulin icodec, it would be 140 times 1.5, so I think that's 210. It's already rounded to the nearest 10 units, so then you would give 210. But from the second week onward, you would go back to this initial dose, which is 140. And then from there, you would titrate based on response. And again, the reason for this, as we talked about, is the pharmacokinetics of icodec, where it forms that depot. And since it's not administered as regularly as other daily insulins, where we can get to steady state within a couple of days, it takes a lot longer, which is where that additional increased dose of the very first week might be helpful to get the right dose to patients so that they can get closer to where they need to be in terms of glycemic control if they're not at high risk for hypoglycemia.
Well, it might be obvious to everyone here, so I apologize if it is. The reason why it's rounded to the nearest 10 is the dose increments on the pen are in increments of 10, just in case anyone's wondering.
Good point. Okay. We'll make a couple of quick comments on coverage, and then we'll go into a cost comparison compared to other basal insulins. In terms of the coverage updates, there was a review from CADEC that was completed on insulin icodec. Also, the product is called iWeekly. And CADEC concluded that they do recommend insulin icodec be covered by provincial plans with the eligibility criteria for type 2 diabetes patients where their A1C is not on target, so between 7 to 11%. Right now, although CADEC has made this recommendation, right now there is no provincial funding that has been approved. We know it is being reviewed by BC Pharmacare at the moment, but as for the other provinces, we're not sure in terms of timelines, if and when it will be covered. Unfortunately, right now, icodec is mainly an out-of-pocket option. Judy very helpfully put together these two tables, which we'll go over comparing both the annual cost of basal insulins, including insulin icodec, and on the next table, we go over per unit cost. But as you see from this table, if we were to look at insulin icodec based on the CADEC review, the annual cost of therapy is very similar to other basal insulins like Tresiba and Levemir. It's a little bit more expensive compared to other ones like Lantus, Basaglar, but it very similar to some of the ones that are on the market now. And if we were to look at cost per unit, which Judy was kind enough to break down for us, taking a look at the price, which, price-wise, it is higher when we take a look at icodec versus any of the other options. But per unit, it is this very similar to, again, Tresiba and Levemir, which these three are more expensive than some of the other options. So from a cost perspective, unfortunately, since it is out of pocket at the moment, this is a consideration that you probably have to talk about with your patients, even if they will benefit from this. Is this something that they're willing to pay for?
If I can just weigh in, if that's okay. I just wanted to thank Judy for putting this slide together. It's super helpful. Even though it's talking about costs, it really adds some perspective into the value for money of icodec. I just wanted to, a lot of the pharmacists might be like, oh, wow, insulin glargine derivatives are so much cheaper, but just be mindful of the fact that those newer generation insulins like Tresiba and Toujeo do have a significantly lower risk of hypoglycemia. So there is value for money there as well. And if you look at the costs of Icodec, it's comparable to Tresiba and Toujeo from what I can see. So it's something I had.
Great. Question, are private plans covering this yet? I know that Novo is working very closely with private plans to try and get this covered. I don't know if it's if they've gotten traction in some of the plans so far, but I know it is an ongoing process. So we'll likely probably see developments over this next time, both on the private and public market, hopefully. Okay, so let's go through some of these. We just have a few more slides talking about the pharmacy role. Oh, and a comment that Assure is covering it. We had our first prescription. Thanks, Kieran. So before we go back to the question that we had in the beginning, we'll just go over some considerations that we talked about. And this is a summary. Number one is considering the type of diabetes. As we reviewed, there's good data for type 2, and although it is indicated for type 1, and you may see it be used, right now there's a little bit less data for type 1 compared to type 2. So we'll see people becoming more confident, both from like a pharmacist and primary care endocrinologist level, being more comfortable with the product and having it be more used in type 2 to begin with before the being widely used in type 1. We do also want to consider whether the patient has a history of recurrent hypoglycemia when it comes to a dosing perspective, and also with the first week multiplier, and also counseling on the higher risk of hypoglycemia with Icodec on days 2 to 4. Dosing will also vary depending on whether the patient is insulin naive or if they're currently on other insulin regimes. And we'll also want to consider adherence. And this might be a flag for us to start the conversation, since poor adherence will affect glycemic control in general. So when you see poor adherence for your patients, I wouldn't say right away, say insulin Icodec, because the adherence could be due to other factors as well, including cost and other characteristics or experiences per patient. But it can be a good option if injection burden is the reason for adherence. Icodec could be a good option. And again, as Siva had talked about from an accessibility standpoint too, there might be benefits to patients who, are not able to get that regular care. And so a more accessible option also of patients we had talked about before for lipohypertrophy, if that is a big issue for them.
Yeah, Molly, you know what? Your clinical judgment becomes so important here, especially recurrent hypoglycemia. You need to see why that's happening. Like we spoke about it before. They might have been just cranking up the insulin because adherence has been an issue prematurely. You guys are the experts. You guys really know whether it's going to be appropriate clinically for the patient, probably because you see them more than a lot of the time the physicians do. So just become comfortable and just recognize the safety of it. I just wanted to answer one question. Is it safe to be injected alongside Ozempic the same day every week? Maggie, really good question. That's actually one of the points that I would say is the main benefit. So if a caregiver is going to come in once a week, they can come in and do their Ozempic and the Icodec on the same day. Just be mindful to make sure it's a different injection site. So absolutely.
Great point. Okay, so coming back to our question that we had before, which of these patients would you want to consider at least starting the conversation about insulin Icodec? And we're not saying that, patient A, B, C, or whatever needs to be started on insulin Icodec. It will obviously be a collaborative decision that you make with the patient, with the other circle of care as well, depending on each individual patient. And hopefully throughout this presentation, you've been thinking about your patients in your practice, especially the ones who may be struggling with multiple daily injections or their current insulin regimen to get to where they need to be in terms of diabetes control. So we'll just quickly summarize these because we still have a couple of slides, and I also want to leave some extra time for Q&A because I know many of you still probably have questions, and we're lucky enough to have Siva here. But quickly going over this, so we've checked off some of these patients. We'll start with B, which we haven't checked off, which is the female age 75, has type 2 diabetes, has recurrent hypoglycemia, and on basal bolus insulin regimen. I'm not saying that you know, she would be precluded from starting insulin Icodec, but in this situation, you would want to think twice about recommending it because of the recurrent hypoglycemia. It would be helpful, especially, you know, if you're able to do a diabetes medication review, or if you're able to, you know, have that patient use CGM to really delve down on why that hypoglycemia is occurring, what are the triggers, what are the times, to see if it's due to their current regimen or things that you can change before really changing up their regimen with something like insulin Icodec. For these other patients, such as A, where they are starting basal insulin regimen, you know, this could be, as we talked about in the very beginning, there are many patients who wait a long time before they start insulin, right? Because they're really afraid. It's very significant to start injecting yourself. And so if that will help the patient, having it be once weekly instead of daily, then it might be something to talk about with this patient. For KC, where we have a patient who is not at glycemic targets and no history of hypoglycemic events, because they're non-adherent to medications, that could be a reason why, depending on why they're not adherent to medication. Insulin Icodec could be a good option for them to help with the adherence if it's due to convenience or the not wanting to inject daily. And the last case where we have a patient on oral diabetes medications and basal insulin regimen, A1C at target goal. So even if they are on target, you can have that conversation with them. And again, there might be other factors here, like are they functionally dependent? Is convenience a big factor for them? You know, are there other things at stake? So it will be a very collaborative decision. Any other additions, Siva, on this slide for you?
Yeah, just reaffirming that, you know, it's really worth doing a diabetes meds check on every single one of your diabetes patients, even if you think they're at target, especially if they're on insulin, because it might be an option for pretty much all of them, right? You never know. So don't make the decision for the patient. Explore all the options with them. You never know where you can make an intervention. So that's what I would say. Like just be open-minded with regards to insulin and any sort of treatments.
We have these next couple of slides that go through a really quick dose example. I know that we talked through it, but it might be easier just to, if we go through it on the slide here. So in this example, we have a patient with type 2. They're currently using 15 units of insulin glargine at bedtime, right? So their daily dose of their basal insulin is 15 units. So what would their weekly dose be? It would just be 15 times 7, which is 105. And again, because of the dosage format, we need to round to the nearest 10 units. So their weekly dose would be 110 units. Now, say, for example, this patient is a patient that we want to do that additional dose multiplier of 1.5. So we would take what we said before, which is 105 units, times 1.5, which is 157 units, rounded to the nearest 10 units is 160 units. And this would be only one time, the very first time they start insulin Icodec. Their first dose would be 160 units. And then the next week, they would go back to 110 units of insulin Icodec.
One thing I would add.
Yeah, go ahead.
Sorry, I interrupted you. I'm sorry. One thing I want to add to this is just, again, assess your patient. All of you guys know which patients would be like, oh, damn, I've been running high there. And which patients will be like, you know what, I'm okay running high for a couple of weeks. Really think about that when determining whether to add this loading dose or not. And obviously you're comfortable as well. Like we've spoken at length about how safe it is to do so, but you need to be comfortable as well. So if it's the first time you're going through Icodec with a patient and they're hesitant to do that loading dose, if you want to agree with the patient, just make sure you give them those affirmations that if you don't do the loading dose, just stick with it and give it, 3 to 5 weeks, however long it takes to reach that steady state.
There's a helpful table here, and we'll share these slides after the presentation. And just as a reminder, it might be buried. Actually, Judy, if you can go back and share our link again for the survey, if everyone can take part in the survey, we'll make sure you get these slides as well. This is a chart just going over if your patient, if this was their daily dose, 10 units all the way to 25 units, then this would be their dose if we added that 1.5 times multiplier for their very first dose. And then if we're not doing the 1.5 times multiplier, or if we're thinking about the following weeks, then this would be their dose, which is basically times 7 and then rounded to the nearest 10 units. And we'll go over some very quick takeaways. Again, as we talked about, Insulin Icodec is Canada's first once-weekly basal insulin, and it's approved for treatment of adults with diabetes to improve their glycemic control. Some considerations include, whether they have a history of recurrent hypoglycemia, whether the patient is insulin naive or already using insulin, their adherence, and we also added their functional independence, whether or not they have other comorbidities and things like that to consider. A really important point, the effect is higher on days 2 to 4, increasing the risk of hypoglycemia on those days. So really important counseling point to make sure patients are monitoring, especially during those times. And we want to make sure that we're administering at least with 4 days between the doses. And it may be used along with other oral diabetes and other short-acting insulins. And that coverage, although right now there's no provincial coverage, CADTH has released a recommendation and it's currently being reviewed from a provincial level at BC, hopefully more provinces to come, and also private plans we'll see them trickling in as well. Before we let you go, we've put together some quick FAQs, so I'll pass it off to Judy to run through these with us. And if you continue to have questions, please feel free to continue to put them in the chat. After we do the FAQs, we can stay on for a few minutes afterwards to answer any other questions.
Okay, perfect. Thanks so much, Molly. So here are just some common questions about insulin icodec. So the first one is, does icodec need to be taken at a specific time of the day? So there isn't a specific time that the patient has to take the insulin icodec. If they're taking it every Monday, any time during the day on Monday is fine. It might just be helpful, to remind patients who are forgetful. They can add a reminder on their phone or on their calendar so that they remember to take insulin icodec on the same day every week. Another question is, how can patients store the insulin icodec once it's been opened? So after it's been opened, it can be stored either at room temperature or in the fridge, so between 2 to 8 degrees Celsius for up to 12 weeks. But make sure to remind the patients just to check the expiry date before they open the pen and use it. And then for patients, another question is, what if they're not sure about the dose that they should be taking? So generally, what's recommended in any patient that's starting insulin icodec for the first time, the normal starting dose is 70 units weekly. So that could be a good reference point if the patient is not sure how to calculate their dose or what dose to start on. And if the patient is already on insulin and they know their daily dose, similar to how Molly was doing the calculations before, they would take their starting daily dose, multiply it by 7 to get their weekly dose to be injected. And then another question that patients might have is what happens if they miss their dose? So similar to some of the questions we got in chat. So essentially, if they do miss their dose, as long as they take the next dose as soon as they remember, and then so if they were normally supposed to take it on Monday and then they forgot to take it Monday and they remembered to take it on Tuesday, they could take the dose on Tuesday and then the following week they can go back to their Monday dose. But the main thing to remember here is as long as you have 4 days between the 2 doses, then that would be safe for the patient. And then for the other 3 questions, what are the benefits of using a once weekly insulin? So, of course, it's advantageous for the patient in terms of scheduling. It's easy to do because they only have to do 1 injection every week, and it helps them to stay adherent and compliant on their medication regimens. As well, it reduces the number of injections. So for any patients who experience injection-related anxiety or they don't want to do so many injections in a week, that definitely is a huge benefit for patients to only have to do it once a week. There are some common side effects, like all medications. So the main ones, like any insulin, are hypoglycemia, hypersensitivity reactions, and then any local kind of side effects at the injection site. So whether it's bruising, bleeding, pain, redness, swelling, itching, or any peripheral edema at the injection site. And then the last question, more around coverage. Will my insurance cover the cost of this insulin? So, reiterating some of the points that were mentioned before, it's not currently covered by any federal, provincial, or territorial public benefit plans. But in British Columbia, it's currently being reviewed to be possibly covered. And it's been given the okay by CADIT for this medication to be reimbursed. So the provinces are looking into the coverage options.
Thanks so much, Judy. And that brings us to the end of our slides. But again, if anybody has any questions, feel free to put them in the last chat, in the chat as I go over this spiel at the end of our presentation. If you also want to raise your hand, and we can also try to unmute you as well if anybody wants to do that. But again, thank you everyone for attending. Big thank you to our sponsor, and big thank you to our guest speakers tonight, Siva and Judy. You really brought such color and richness to this session this evening, so really appreciate it. I loved all of the discussion and really the practical guidance and your expertise, Siva, in terms of your practice and speaking with endocrinologists and speaking with primary care. And I think, this is a new topic for us, a new product. And so it's exciting to see something as an option for our patients who really might benefit from it. So really appreciate everyone on the call today. Amazing job. Thank you, everyone. Okay, thanks so much.
Thanks so much, Molly. Thanks, Jude. Great working with you.
Yeah, wonderful. Okay, thanks so much, everyone. As a very last thing, if you haven't already, please fill out our survey. If you have any other questions after we end this in a minute, then please reach out to me and we'll follow up with you. Okay, thanks everyone. Have a great evening. Here.